This is the EMS Research Vlog and Podcast, where we talk about the research-related issues that matter to those who work or study in the area of emergency medical services. Your host is Bram Duffy, who is a paramedic and communications professor.
Welcome to the EMS Research Vlog and Podcast from the studio here in Houston, Texas. I want to start out by drawing your attention to our website where you can check out anything that's show related when you go to professorbram.com. That's professorbram.com. At the website, you can find the latest show, see my talks in the media, order the latest book, and also look at how to participate in research. This is all stuff that can help you grow in the world of EMS research. Like right now, I have a research study open for first responders. So if you don't mind being interviewed by me, then go to my website at professorbram.com and click on the current research tab to apply. Hennepin EMS in Minnesota introduced a groundbreaking pharmaceutical consulting role early on to enhance pre-hospital care, like around 2023. This role formally integrates clinical pharmacology into EMS operations. And this kind of thing addresses challenges like drug shortages, offers creative solutions for medicine use, and helps with collaboration between paramedics and pharmacists. And this initiative stems from years of informal partnerships, right? Like we have with clinical pharmacists and emergency departments. But this Hennepin EMS saw the value of adding an expert who understands the unique demands of the field and the space and the storage and safety constraints, as well as the need for cost-effective and efficient medicine alternatives sometimes. So key benefits are things like improved collaboration, right? And enabled shared understanding and help figure out better protocols. So I was impressed with this, and I got to get a hold of this clinical pharmacist who works with Hennepin named Holly Drone. And so I invited her to come speak with us today. And I have some questions for her, but before I get into it, there's so much cool stuff about her. I wanted to give her a chance to just introduce herself. So Holly, welcome. Go ahead. Tell us all about you.
Thank you very much for having me. First off, I guess I'll say I'm a Minnesota native. I was born here in Minnesota. I did travel briefly to complete my undergraduate studies in chemistry and business at Notre Dame. So I spent some time in Indiana, spent some time in Chicago for a little bit, but made my way back here to the University of Minnesota for pharmacy school and kind of have lived here ever since. I work for Hennepin EMS, as you said, but my history here with Hennepin County Medical Center and Hennepin Healthcare is actually dates back to when I started school back in Minnesota for pharmacy school. So I've worked here ever since in various capacities. Graduated from 2 years of critical care residency in 2015 and worked a lot in critical care burn and pediatrics. But my passion is always has always lived in emergency medicine. And I was fortunate enough to be able to take a position as one of the primary emergency medicine pharmacists here at HCMC, which is an amazing program in a teaching institution. If you're not familiar, we have a really rich, diverse patient population and a really wide range of patient and employee backgrounds. So I absolutely love this place. It has my heart probably forever. After I joined the emergency department, which was about 6 years ago, I kind of informally, like you mentioned, consulted with just mostly the medical direction team with Hennepin EMS, who also cross work in the emergency department, kind of in an impromptu role. And we can talk a little bit about what that looked like. And I currently serve both right now in the emergency department and with Hennepin EMS. I have a really wide range of clinical interests. One thing is that I really love medication safety and process improvement. That's something that has developed over the last 10 years. I really am interested in trauma-related resuscitation and hemorrhage control, as well as things that are more in the mobile integrated health system initiatives such as like opioid use disorder and treatments with regard to that.
Okay, my goodness. So you know, the connection was there because you all are in the same vicinity, sort of working together. But what was it about Hennepin EMS that said, hey, we need this role. What was the trigger there? Because I want to clarify, you're not a nurse or an EMT, right? You're strictly a clinical pharmacist. So tell me more about how they were like, yeah, let's do this. Let's be one
Yeah.
of the first.
Yeah, I mean, we've been building this kind of as we go. And I think it was a lot of it during COVID when we started really experiencing really severe drug shortages. Was one of the big niduses for us to start talking, mostly between the medical directors and myself, as well as some of the operations staff. As you know, you probably well know, most agencies work either through a pharmaceutical kind of like stocking or purchasing company, or if you're affiliated with a health system, you work through kind of the operational folks there. With that, people do speak different languages though. And when drug shortages hit, medical directors and EMTs are not, operations command staff are not trained or have any background in what do you do when your normal 10 to 30 meds are not available. That requires a little bit of extra, I think, expertise. And so they came to me with lots of questions about like, what would we do in this situation? What do you think about this backup plan that we are proposing? Is it available? How would we store it? What are the things we need to think about in the medications that aren't standard for EMS? Or, how should we alter our protocols to deal with drug shortages? Those were kind of the main things we were first discussing. But we also, like I mentioned, work in a teaching institution and we train a lot of paramedics. So they also have like a lot of complex, just inquisitive clinical questions about how to use medications, what should they look for? And, most medical directors or, operations staff can answer basic questions. Both the medics and the medical directors came to me with a lot of those questions. That led to me just starting to look at what does a protocol look like. Before I started working with this group of people, I didn't even know really how EMS ran. And with that, those things take a lot of time to learn. So we started kind of having some real in-depth discussions about how much time I was spending in my off time, like helping just support a group that I actually, number one, respect the amount of work that people do in this field, whether it's frontline workers, whether it's behind the scenes staff in preparing protocols, looking at data, looking at med safety, looking at just stocking an ambulance. Those things take so much time and effort. So as I learned more, it was really an area of growth that I enjoyed. And ultimately I said, it's really hard to do this when I'm on shift in the ER. We are one of the busiest ERs in the Midwest, seeing over 100,000 patients in a year. And it's hard to keep up. And pharmacists historically do not get a lot of administrative time to do things that are outside of direct patient care. And I was fortunate enough to have an extremely supportive team here at Hennepin EMS who said, all right, what could this look like? How much time do you need? What do you cost? And, what would your roles and responsibilities be? What could you take off of other people's plates? And all those things combined, made a position that, started off lower 2 years ago in time. And we've slowly grown it through some funding that, I've been involved with via grants and mobile health and things like that. So I've been really fortunate to both have a really supportive team, both from the medical director side and the operational side, to grow this role into what it is today and what it probably will continue to grow to be.
Yeah, so Hennepin EMS is kind of big, right? When I looked at the website and the coverage area, can you comment on that? Because, I don't know that everyone has a department with funds for this.
Yeah.
Like you're saying.
It is a really big service area. So we serve multiple counties in the Twin Cities, Minneapolis and St. Paul. We are affiliated with Hennepin Healthcare, but are, somewhat of a separate department on its own. Our transports, I don't have the exact numbers on me, but are, near 100,000. If I don't quote me on that, I can correct that if I need to.
You have a large population.
It's very big. We have somewhere around 180 paramedics currently employed. We run up to 39 trucks on a given day. At a given time is how many we have. And so We have 6 medical directors. So we're a very busy service with a lot of needs and a lot of high acuity patients. And so we are fortunate enough to, we are a safety net hospital, we are a county hospital and a county health system, or affiliated health system. So we aren't made of a ton of money. Fortunately, when you look at various people doing jobs such as, assisting with medical direction, a pharmacist is considerably more affordable than, say, a physician. Their time would be. And I was able to support part of my role with grant money, because I do support some grants that we have brought in since then. But really, to their credit, they put me as a priority in the budget for a certain period of time to try, and it's been successful. Some other things that I've done to support my role is looking at medication cost and efficiency and use. So especially with drug shortage, we started paying a lot higher amounts in drug costs. So we've talked about the PAR, the amount of medication that we keep on the shelf, and how long does it last on the shelf? Can we store it differently to last longer? Can we obtain a different formulation or a different way that something's stored so that it's a little bit more affordable? And then we've worked on some funding to get reimbursement for things like naloxone through the state of Minnesota. So there are ways to offset it, but ultimately, I've just had a really supportive team here who has seen the value of the dollar.
Because it takes time.
It does.
You do have to put a lot of time into this, right? I'm imagining all kinds of different facets. And I'm also thinking about what kind of feedback did you get from paramedics and maybe patients about your role and how you're on the ambulance? Because when I'm with folks who are not used to being in EMS, kind of like you're talking about, I read about how you had done, ride time. And so I didn't know, how those things worked as far as, were you ready? Did they give you combat boots? Did they, equip you? Did you have surprises? But I'm kind of interested in just what that dynamic was like, because you were on the truck a little bit, huh?
Yeah. So what started as just trying to understand, like, how do paramedics use their medication on scene? Because again, as a pharmacist, like, that is nothing that is ever taught to us. We get a short course on critical care medications, like short course on, cardiac arrest and things like that. But it's not something that's focused on even in training. If you're emergency medicine trained, which is a rare program for pharmacists, but is growing, you might get some of that. So I started riding with the medical directors. So they have their own kind of squad car that they pick and choose and, go to high priority calls, et cetera, just to learn. But I quickly realized that the more I was on scene, the more questions were coming to me, the more like feedback people would give me. So at first it was a little confusing. Everyone's like, who is this person? Is she a medical director?
Right.
Is she an EMT? So, and to a lot of people, a pharmacist is someone at, a local pharmacy, or they do interact with me quite a bit in the emergency department when they bring in critical patients. So I was fortunate in that regard. So a little bit was confusion, but, I don't function as an EMT. I'm there to help educate. I'm there to a lot of times just learn. But it was always positive. It was just more of like, why are you here? Like, inquisitive nature. I tend to kind of stay out of the way, but, when I am on scene, we've realized that there are definitely areas that I can be useful as a pharmacist. In more critical cases, for example, we had a patient with hypoglycemia at a nursing facility. And while the medics were busy treating the patient and correcting the hypoglycemia, packaging the patient for transport, I was able to actually talk to, for example, the nursing staff and ask them, what's been going on? What medications are they on? They, usually they just hand the medics a MAR and say, I don't know what happened.
Mm-hmm.
But in talking to the nursing staff, I realized that they'd been giving insulin incorrectly. Because this had happened now 3 times. And that's where something about, I might do that in the emergency department very routinely, is look at a MAR and figure it out. But in talking to an actual staff person on scene, it was actually the only way we would have known that a medical assistant was actually drawing up insulin incorrectly. And things like that have been really beneficial in kind of creating buy-in. It is another person on scene, and I'm well aware of that. There's a lot of cooks in the kitchen. And so, I go out once a month. It's not a super common thing that I'm riding all day, just based on mostly time constraint. But we've had some great, discussions about education. The medics are really open to like finding me wherever I am in the department when they come bring patients in now. They email me, with questions and feedback. Sometimes it's even feedback about how a protocol is unclear for a medication, which I absolutely love because we then have discussions on the, back end and sometimes, that changes even just a protocol in the way it's written so that it's more clear. So it's been nothing but positive, especially once people understood kind of what we're building here.
Because paramedics don't get the same pathophysiology and understanding. So when we are fed that stuff from pharmacists and from physicians, that, it's like a sponge thing for us. But, I'm imagining you and I are on a scene together and we have a moment to talk, and we were working together in this kind of situation. I have to tell you, I might joke with you a little bit about how this is how we do things out here in the field, because it's funny to me for you to sort of frame it like to see how things are done when you are the expert in how things are done. And what we have is we have some paramedics, and I'm not going to say I didn't do this when I was younger myself. We have some paramedics who look at that medicine kit and spend time imagining how fast they can get those boxes open, the ampules popped, the cartridges put together, thinking about how they may have to rip open something with their teeth and do the rescue emergency superhero aspect of it can come down to giving that actual drug. So when I was brand new, for sure, I did a lot of mental exercises about, okay, I have a patient, this is what's going on, grab this drug. And I had to think about the route and what size needle am I going to get. And so I don't do that anymore, but I know I kind of did when I started. So you're interacting with all these folks who are mentally prepared to administer drugs as fast as humanly possible in some cases. And so I just wanted to say I get a kick out of it because I'm thinking about how you're checking out things on the street, but really you're the expert.
I mean, the thing is, I'm not the one always giving the medication, like I watch nurses do it. I watch, EMTs or paramedics do it. And that has been a really good, I think, reality check. And it's also been a really good reality check for my learners who come out with me, the pharmacy residents that we bring out, and just getting an appreciation for like, we know exactly the onset of a drug and how fast you should push it and what could happen. But what's really challenged me, which I have so appreciated about EMS professionals, is they've said, but what if I do it wrong? Or what if the reality is that in the scene, like this is going to get pushed over 10 seconds, not 3 minutes. Like I don't have 3 minutes. Is that harmful? And that has been really good perspective to get, because the real world is not always what everybody is taught in school. Even I think in paramedic school, it seems like, the reality on scene is just different. And it's important, I think, as a pharmacist to also recognize that the data we have is limited and that the way we use things is different. And that's where like I've really enjoyed doing a lot of like medication use evaluation through EMS, and figuring out like, because there's not a lot of data on like adverse reactions, and medication errors are underreported, and looking at that from a lens of non-judgmental, like just pure, like how are we using medications standpoint, I think has its benefits like across the board and nationally if we can really like show that, there are ways to do things that are easier than just the literature way of always doing it. And they're still safe and they still provide excellent patient care and patient outcomes. And I think pharmacists are uniquely positioned to analyze that data, in conjunction with people who, work in the front line or who work specifically with quality and data. So that's been a very exciting part of my position as well.
I love it. And that's one of the reasons I found you, because you've recently authored like some stuff that I wanted to ask you about. But before moving on to that segment where we talk about your work, I just want to see what you think about reflecting back like on our conversation and your experience in this role. What do you think that this could look like for the future of EMS and pre-hospital care? And, because is this something that, those level 1 trauma centers who are able to have a person like you, does that mean that those roles need to expand in different ways? Tell me, what are you thinking for this?
Yeah, I mean, obviously no there's no projections or models that you're ever going to find to do this at this point in time. My role is relatively one of a kind. Most people who are assisting EMS are already part of the emergency department or are operational or purchasing focused, just kind of get the drug to the company kind of thing. So things when I think about now that I'm, 18 months to 2 years into developing this, things that I think in the future, the way this could look, pharmacists are really well versed in, drug interactions and drug administration and drug dosage. I think especially for maybe not as wide and large institutions as ours or, agencies as ours, like being able to assist multiple agencies or an agency in making sure that the way they have their medication protocols or references written are effective on scene, so that people who are on the front line can make rapid decisions that are safe and effective, and ultimately have like good outpatient outcomes is really important, is something that could be, I think, more standard. Other things that, training is really important. There are various levels of medic school. There's various levels of even pharmacology lectures, like you said. And so pharmacists being involved in that and giving, both a real-time perspective as well as like data behind things in pharmacology, from their perspective, I think could also be a huge role. And I think all of that, supports things like there's, futuristic thoughts like telehealth. We have whole divisions of EMS that do mobile integrated health, that do community paramedicine, that support public health groups. And, pharmacists could be available via telehealth for home visits, to assist. We know that a lot of hospitalizations and a lot of ER visits are related to either patients misusing their medication on accident, or not taking their medication or lacking access to medication. So those are also, ways in which pharmacists in an institution like you're in a pre-hospital setting could function and could be of benefit. As services look at things like, in lieu of service. So, paramedics seeing a patient, treating them via telehealth and not actually transporting them to the hospital for low acuity things. Pharmacists could be part of that med control call. Physicians are not necessarily, always trained on like, how do you make sure a patient has access to a medication that they need? They don't necessarily need to come to the ER to get, a refill of their medication. We could do that from home. And I know that's not the traditional role of EMS, but the reality is that, part of EMS is moving in that direction.
Yeah.
I think pharmacists could be part of looking at data models, and linking them with public health data to do things like, where do we target overdose prevention classes? Where do we station even paramedics in the right spot, in the city to be of, more rapid transport? How do we train those people to use medications, like naloxone or buprenorphine? I think there's a lot of ways in which pharmacists could be really beneficial.
Yeah, and this treating people and letting them stay at home kind of model is pretty popular in the UK when it comes to EMS, and not so popular, here in the US right now. But if for nothing else, it seems like with technology advances happening, this could maybe become a necessity someday. I always joke about, but it's true. I'm ready to do ECMO in the field, right? So if that's what I'm thinking for, where we're going, there's definitely room for you. And I wanted to say that I was impressed with all these publications that you've been doing. And the Pre-Hospital Emergency Care Journal published something from you just this last year titled Massive Sodium Nitrate Overdose, a Case for Pre-Hospital Methylate Blue. And Sodium nitrate overdose can be something that's really dangerous and, well, often deadly because it causes a serious condition. And um, really, when the blood can't carry enough oxygen, it really sets things up to um, provide a way of death. And we know that the S word is also associated with this. And so there's a treatment called methylene blue that can save lives, but it needs to be given quickly to work. And so the case report that you kicked out discusses a tragic death from sodium nitrate and how it kind of led to the creation of the protocols. And so I'd like for you to share with me, what motivated this, and tell us more about being able to put this together in quick form to save a life.
Yeah, so like you mentioned, these cases are often very tragic, and unfortunately, for the general public, sodium nitrate is available on places like Amazon. And it's a scary situation when it's ingested because death can come within 20 minutes. In the worst cases, and so you don't have time to dispatch and get a patient packaged and transported to hospitals that quickly, and then get an antidote and things like that. And what happened is we are connected to the Minnesota Regional Poison Center, actually housed in the same building. And so we have this amazing team of emergency medicine physicians and toxicologists who also work here. And we had several cases where patients ultimately died because we couldn't save them fast enough. And that's the reality in a lot of these cases. So it prompted the question of what could we do to improve the time to this critical medication.
So were your cases powdered fertilizer, or what were you seeing?
I know one of them was actually a kit that someone bought online to take, and the patient like scooped it and put it into a drink and drank it with the intention.
Wow.
But then I don't recall if that person called EMS themselves or someone called for them. But we basically said, like what could we do to make this, like, how could we correct this faster? And, the reality is get the patient the medication faster. Like we can do airways and we can do all those things, but the hemodynamic changes and the hematologic changes that happen so fast, like an airway is that's not going to ultimately save the patient. And so we said, what if we tried to put it in the field? And what would that look like? Obviously, we have a big service area. We have a lot of ambulances. The big challenge is that methylene blue is not super cheap. It's cheaper than it used to be, but to put several vials on every ambulance it's just not financially feasible if you're for cases that are relatively rare. So we decided, why don't we store it in our command vehicles? So the supervisors, it was a new process for me to help dispatch also, like, update their protocols. So how do we recognize this from the dispatch side early so that the command vehicle and the supervisor could be dispatched at the same time as the ambulance? Whether they're able to meet the ambulance where they're at, because we don't want to delay transport either. It was a really multidisciplinary group effort. We fortunately, I will say, since we deployed it, have actually not had any cases, but we will certainly be ready when we do.
So the methylene blue, if it's administered to someone who actually, didn't partake in the overdose, what's the cost benefit analysis look like for that? Like, maybe, if you have a suspicious sodium nitrate overdose versus confirmed, what do you think about that?
So we have talked about that quite a bit. It is a potent vasopressor. So you can, if someone hasn't taken sodium nitrate, for example, like we had a suspicion, but not, we require a med control call for that if it's not very clear. A lot of these patients or family members will call and say, like, I did this. And so it's very clear that they did that. I think if we were just suspecting it, we talked about having a med control call so we can talk to the poison center, which is a very quick call for everybody, and something that the paramedics in our system are used to doing, calling poison center if there's been an overdose of some sort. And then we would decide the risk benefit of it. It's not thousands of dollars, it's hundreds of dollars in the scheme of things. So like cost wise, I'm not so concerned if it was given, but it can cause
vasoconstriction.
Yes, it can cause vasoconstriction and can cause hypertension. So that would be something that, we obviously need to be aware of the risk of doing in any case.
So if you're doing this with sodium nitrate, what about the same concept for something like another kind of overdose agent, right? Like if you have organic phosphate poisoning, why not have a supervisor vehicle with a bunch of atropine? Because we don't carry enough on the truck for that, and it's kind of similar. So I wanted to see.
We actually do have a large stock of atropine in our command vehicles, and we actually also have cyanokit.
Okay.
So we actually, those are two other things that we actually have. We have in our supervisor vehicles. Those are things that we've actually done in the last couple of years.
So is that you're doing?
Yeah. No, I mean, I've been involved. All of these things are, we have a really great, like I said, toxicology department, but we also have Dr. John Hick, who is a national leader in disaster management and emergency preparedness. And so we have some, we have a great group of people who are well versed in this, and we've had the support to do those things to be ready.
Well, that's really great. The other article that was out just this last year in 2024 that you helped author was feasibility and safety of oral risperidone to treat pre-hospital agitation. And this is the study that evaluated the use of oral risperidone in managing agitation. And it's like setting up a chart review is how this happened. And they 552 cases over 8 months. And of the 530 patients, almost all of them accepted it. And there were minimal problems. And it's just, when I think about this from a standpoint of interacting with folks that are psych agitated, having a pill to nicely coach people through, I can imagine in my mind, gosh, this is not going to go well. But your studies show that they all took it, most of them, right? So this is a lot different, because traditional treatment is like an IV or up the nose kind of medicine, right? So tell me about this. How did the paramedics adapt to you have an oral dissolving form, right? How did that work out?
That's correct. So we were looking for ways in which we could provide therapeutic benefit to patients who are anxious, who, are experiencing, anxiety over many things, or, mild agitation, whether it's a psych component, a substance use component, or, anything else. It is really easy to administer, and so it dissolves on the tongue. You have to swallow it still, so a patient has to be appropriate for those things.
Yeah.
And it does take a while to work. It's not immediate, like other agents that would be given IV or intramuscular. So it has to be the right patient, which, I think part of it, in the study, we report an almost 97% acceptance rate. Our medics are not required to document refusals of all things, and so they do document it many times, but, part of that is just the right patient that they're offering it to. There's a growth curve in adopting it, because it's a new way to treat, a very common thing that they see. But, paramedics are faced with, increasing amounts of patients who are altered, agitated, anxious. And so I think that they were really willing to try other things. Nobody likes to give intramuscular medications. No one likes to try to get an IV on someone who's agitated. And so once people started realizing that, sometimes just that peace offering of like, I have something to give you that will make you feel better by the time we get to the hospital, it can help your anxiety. It may, help any, other ailments that are related to that. It might make you calm down or take a nap for a few minutes. Sometimes just that offering is what a patient actually needs to de-escalate. And once they, started doing it and saw some success stories, and as always, there's champions for these things, that have as sharing their success stories. We had a really good uptake with it. 530 patients in, 8 months is a lot. Obviously we see a lot of patients. It's a pretty safe medication. We had multidisciplinary, discussions about the dose we were using, the medication we had options for, because there are other agents as well. And this was, ultimately the one we chose. And we've been really happy with our ability to offer alternatives to intramuscular and IV medications for patients.
Yeah, it's so nice now that I think about this on the back end with good results, because honestly, I don't know that I would have, thought about it the same way, because now that I've seen your success story, I'm thinking about how instead of doing something to someone, we're offering something, right?
Yeah, exactly.
It's pretty cool.
And I think that everybody feels better about that. Obviously some patients just need something that is a little more strong or a different route, or, there are definitely places for all of those, all the medications I think that we carry for agitation and for anxiety. But this is a nice complement to those.
Well, you were also really busy and have another authored publication that was out this last year called Feasibility and Safety of a Paramedic-Directed Prehospital Buprenorphine Injection Protocol for Acute Opioid Withdrawal. So we're talking about helping folks with opioid withdrawal. And this time you had 121 cases, right? And so dealing with Narcan and dealing with the sickness of the opioids. How did this work out? Tell us how it fixed or didn't fix, and what does this look like for the future now?
There's a lot of things that we have learned over the last year and a half in using this, and we had a few agencies who are using this before us. We've had really rapid uptake in it, which has been a great success, and the team and the paramedic team have really embrace this and in offering it to patients. I think it helps in two different ways. One thing is that it immediately treats the symptoms. And so that was something that we reframed. Obviously it can get people a bridge to starting on buprenorphine or Suboxone long-term for opioid use disorder, to prevent overdose and to lessen opioid use, et cetera. But ultimately, like the other big success we have had is that we have something to offer patients who feel absolutely terrible. And that solution is buprenorphine. And so if patients, meet the criteria, aren't on methadone, don't have other risk factors for precipitating worsening withdrawal, it can make their symptoms, rapidly better. It can also make them a lot easier to then assess for other issues that they may also have going on at the same time. And so, our paramedics have seen that like patients calm down on the cot, they're able to be transported comfortably. It has the added benefit of then preventing overdose when they discharge from the emergency department. Many agencies in the country who are using this now, patients don't have to be transported either. And so you could safely leave someone at home with this if it's the right situation. And that has been a really good thing. I think from the paramedic perspective, they see so many patients getting Narcan. They have seen so many patients in withdrawal because they lack access to opioids or lost access to opioids. And there wasn't always much you can offer them. You can offer them anti-nausea medications. You can offer them transport. You can, offer them conversation. There's only so many things, maybe droperidol that can help, but ultimately to treat it, this is, the answer that they were offered and have really had success using.
So what was the route that was used?
We use sublingual tablets.
Yeah.
There are injectable forms of buprenorphine. There's short acting and there's long acting of those, which are less I would say, less familiar in the pre-hospital setting, although they are things that we are exploring and discussing and looking at. But we use the traditional sublingual tablets, which are, you have to, it takes a little bit of learning curve just to learn how to do it, because it's not orally disintegrating. It actually goes under the tongue and has to sit there for 10 minutes. And, you're not supposed to drink water during it, et cetera, et cetera. So there was a little bit of teaching that went along with that. There's some teaching, about who is the right patient so that you don't have adverse effects from it, et cetera. But ultimately, it's a really safe medication when used in the right situation. So we've had very little adverse effects or negative outcomes.
And so we're doing all these drugs under the tongue. And what else do you have in mind for drugs under the tongue? Because you've already put out 2 studies for that kind of route. Do you have other ideas for the future?
Not super tangible ones at this point in time, but there are other medications for anxiety agitation, like Zyprexa is one, or olanzapine, are other options.
But I just want to mention, even Zofran is offered this way, so you can get
absolutely. Yeah, and Zofran's, the sublingual things, like buprenorphine, are a little more finicky than ODT, or like orally dissolving, which you actually just swallow after it dissolves on your tongue. So those are super easy. And Zofran is that way, or ondansetron, and then the risperidone that we talked about is also that way. They tend to be a little bit slightly more costly than the normal tablets that you would just swallow. But when someone who feels terrible, or is sick and ill, then those are much more tolerated options, I would say, and easier to give.
Yeah, for sure. Thank you so much for doing what you do. Do you have last words for us, or anything that we missed together in our talk that you want to kick out there to our audience?
No, I just, I respect this team here at Hennepin, and I just want to, obviously I always say thank you to them, because they have embraced my position and all of my ideas, or my critiques of their crazy ideas at times, with open arms. And they are such a supportive team, both operationally and clinically. I would hope that the work that we're doing and the work that I'm doing can eventually be a model for other groups to have the same successes that we are with pharmacists.
And that's what you are. You're a model, because we're thinking, right now we can list, some of the big services that do big things. And now, as of today, I just added Hennepin to the list for me. So great job for them and for you. And thank you again for advancing the field of paramedicine research.
Awesome. Thank you very much for having me.
Like many of you, I'm also an EMS instructor, so I know what it's like to have topics that are important to cover, but are not actually in your curriculum. So when it comes to EMS research, I want you to know that I've been joining EMS classes lately in a virtual kind of way. It's fun for me to meet your students and talk about EMS research, or even talk about how things are done differently where I am versus where you are. So if you're an EMS instructor like me and you want to give your students a flair of what EMS research is all about, just fill out the inquiry form on my website at professorbram.com. This is professorbram.com, and I'll be in touch. I want to also invite you to check out my latest book. I co-authored it with 4 Arrows, who has 2 doctorates and is an expert on indigenous scholarship and hypnosis.
We've got to look at each individual patient as a human being who is in need. And we've got to know that when we're in need, we do look to others, no matter how self-reliant we are. If we are in a situation that we've never encountered before, that self-reliance begins to seek, is there anyone that can help me with this situation? I mean, you've used a pretty drastic example with the arm cut off, but I don't care how much skill you have. There's very few people who would be able to not say, "Oh my gosh, I need help," and then all of a sudden someone shows up
with a badge.
Yeah, and you think, well, maybe this is someone that can help. Well, you said that, and I said that, during the first hour of trauma, people are essentially in a state of what we now know is hypnosis state.
I want to invite you to check it out because we introduce a method for communicating with patients on the scene of the emergency that takes advantage of some of the properties found in hypnosis. The book works to change the way we approach and interact with any emergency patient who's in acute distress, and it can help you be a better practitioner. The book is called Hypnotic Communication in Emergency Medical Settings for Life-Saving and Therapeutic Outcomes. Follow a link there below to find it, or you could get it almost anywhere books are sold. And if you contact me, I would be happy to mail you an autograph sticker designed to be put into the jacket cover.
Hi, I'm Will Chabot from the International Prehospital Medicine Institute. You might know about us because of the literature reviews that we post every month free for your review on our website at iphmi.com. and also published through GEMS Online Magazine every month. We've been doing them for 5 years, so now we've accumulated over 240 literature reviews over the past 5 years. And we've gotten feedback from our audience that said they'd like to have these things as desk references, so they'd had a rapid reference. Well, we've done it. And there are now 5 volumes of these books, one for each year that we've been publishing them. This is the latest version, volume 5. And as I said, in each of these, there's at least 48 literature reviews. They're all cataloged in the beginning of the book, so you can see what the topic area is, what pages those reviews are on, and how you can find them quickly. Again, these are a great reference whether you're putting a lecture together, working on a paper, studying, whatever it is. This gives you the depth of field of the science that dictates what we do in the field, or what we should be doing in the field, or why we've changed the way we do things in the field. In any event, as with all of our publications, we've priced these because we want you to be able to have this book. It's only $4.99 in the hard copy here. And they're all 5 of them are available at that price, but you can also get them as ebooks, and they're available as ebooks from Amazon, from Apple, from Barnes & Noble, wherever you get your ebooks for the price of $2.99. So again, we don't do this with an aim towards getting wealthy. We do these because we want you guys to be able to have these materials, relevant information, affordable information, and an access so you can get to it. So you want the hard copies, go on Amazon, $4.99, go to your ebook store and you get it for $2.99. If you're in the business, this is the kind of material you want to have around to settle those firehouse arguments or to help you put your materials together. Thanks again. See you all soon.
I'm doing a research project related to first responders who live in the United States, and I could use your help if you don't mind being interviewed over a video call. Go to my website and fill out the form. It's at professorbram.com, professorbram.com. I just want to thank you for listening, and I look forward to sharing more insights with you in the next episode. If you enjoy EMS research, please tell your friends and like, share, and subscribe to help others get the message.